It's a bright but quite relaxed morning in Salaga as the town comes alive with activity. For the staff at the municipal hospital, however, their hectic schedule has already started in earnest as patients crowd the facility seeking attention for various ailments and medical conditions. Most of them started arriving at the hospital at dawn.
The OPD is the first stop for any patient who comes to this hospital.
There is only one doctor here for a town with a population of 220,000 people. This is clearly a considerable challenge for the provision of quality health care here. I spoke to Dr. Allen, who was actually standing in for a friend.
My friend who runs this hospital is the only doctor here. So that's why he's arranged that someone has to be here if he's not present.
Of course. At the children's ward, the administrative nurse has already booked in most of the sick children. They are with their mothers and relatives, seated at every available space in the wards, waiting. Eventually, Mr. Tabiao, the senior nursing officer, arrives at the ward and starts his rounds in earnest. He goes about his task painstakingly. Some of the children have been waiting for several hours and look quite ill. Mr. Tabi is assisted by a nurse and a nursing student, and it would seem they have visited other wards before getting here. Mr. Tabi works long hours and is clearly burdened by a very heavy workload. We managed to talk to him.
I'm not the doctor, but I'm representing the doctor in the ward. The commonest cases we get here are gastroenteritis cases and then malaria cases, most of them. And at times, occasionally, we get pneumonia cases here. And so when we get them, at times, because the laboratory is always busy, so we use our own discretion and then the clinical findings, and then we start with the treatment. So at times, within 24 to 48 hours, most of the patients are fine.
So you have plenty of referrals that come to this location?
Yes, we get referral cases from other substations. We have the sub-district referring cases to this place. And then we have cases coming from consulting room to the ward. And some also, they come direct from the house to the ward. Yes.
You must be tired.
Yeah, very, very. We work almost 24 hours. So when cases come to the ward nurses will detain the case, and then they will start with their treatment. Then they will call you the prescriber. Then you come in, and then you do your examinations, and then you continue with the treatment.
Is there a doctor coming in today besides yourself?
Yes, if there is the need. The staffing capacity is very low.
Okay.
As I'm here, when I finish, I'll go to the female medical ward too.
So you have another ward you have to visit?
Yeah, female medical ward.
And it's not even lunchtime.
No, it wasn't up
So
to
there's
lunchtime.
more who are coming.
More who will come to the ward.
So who takes care of the doctor when the doctor is sick? Before we left, we got to talking again to Dr. Allen, who provided some keen insights into the situation in Salaga.
We need a more equitable distribution of manpower, critical manpower. I think there's too high a concentration of doctors in Accra and Kumasi. If there's one thing the health sector can do, more education for the public, more ongoing education for the health professionals, growth in the economy. As people are economically empowered, they would have the resources to take better care of themselves. But we'll do our bit to help when they get here for the good of Ghana, our motherland.
I am afraid.
I've donated once.
It will make me impotent.
I don't have enough blood.
I'm too busy.
I don't care.
Stop giving excuses. Start giving life.
Good evening and welcome to our discussion segment. I have on my left Wafayao Tebi, Senior Nursing Officer at the Salaga Hospital. He doubles in charge of the theatre, he handles the female ward as well as the children's ward we saw. Wafayao, you're welcome.
Thank you, sir.
And on my right, I have Bright Apia. He's with Child Rights International. Bright, you're most welcome.
Thank you.
Now, Wafayao Tebi is a Senior Nursing Officer placed at Salaga Hospital. He's been there since 1998. He's well positioned to tell us and explain to us what we saw. Is this the typical picture in Salaga?
What you saw is not the true picture. It's only seasonal. Within the hospital, we have within some year, some period in the year that we usually get plenty admissions. So what you saw, it was the patients and their mothers that were lying down. But the ward has got some few number of calls. But because it was within the peak, the patients outnumber the calls.
How long does this seasonal peak last?
Usually, the seasonal peak lasts about 1 month or 1 month, 2 weeks that we usually take. And mostly what happens is that most of the patients, they don't come within the East Gonja district of Salaga. Some of them even come from Nanumba district, either Nanumba South or Nanumba North. And the reason why they usually come to crowd our ward is that they always feel that Salaga Hospital gives the best of care.
Is that a feeling or the reality? It means that the peripheral facilities are not providing the quality of care that people have a right to and require. So they come to your facility.
Yes, our facility.
Right, and I don't think that perception is seasonal. If I know where the doctors are, where the drugs are, it's not a seasonal thing. It's a matter of life and death. We found out that Wafayao doubles as the head of the theatre because he has the requisite skills. He handles the OPD cases, so you run an outpatient department. You also run the children's ward.
As well as the female medical surgical ward.
Right. So looking at you, you have 2 arms. You're not an octopus. How do you do this? And why has this been allowed to persist for so long?
Yeah, what I started doing hasn't persisted for long. It has taken just about 5 or 6 years now. And that one is due to lack of prescribers.
The situation, Bright, at Salaga, what are your initial comments to this?
No matter what the season dictates or whatever it is, even if it is one child at a particular time, the system requires that we need to give that child a maximum attention when it comes to healthcare. They have a right to quality care. You need a doctor, and looking at the area, you need more than one doctor to be able to deal with the issues. And when it comes to handling children itself, it's a very technical area because when it comes to that, you need all kinds of people to be in that particular department. You need a social welfare officer, you need a clinical psychologist, you even need a child psychologist, including a doctor in that particular area to be able to deal with the issues, because most of the issue that comes to the children department is not only about sickness, it has to do with psychological issues and trauma that parents face and all of that. Because medically, it has also been proven that yes, when a woman is pregnant and the woman goes through certain kind of trauma, it even affects the child. So you'd also need somebody to be able to take care of that aspect of it. So it's a whole institute on its own. So if you have one person there doing all kinds of multiple work, it clearly shows that the child is not getting the best. So whatever we do, the best interest of the child needs to be protected. Children are lacking certain things, and that is not related to only Salaga. I have been to Kolebu Children's Hospital. I've been to Konfanoche. You see this issue cutting across, and I think that it has become a national issue that we have to deal with at that level, because if you don't handle it properly, it means that we are undermining the health situation of our children.
This raises an issue because Ghana was quick to sign up to some of the child rights conventions, that we have a Children's Act and so on and so forth. And you coming from your angle as a child rights advocate, saying this is a general picture. It means that what we say and what we append our signatures to as a nation and as policymakers doesn't manifest on the ground. Is that what you're saying?
It is, because there is a clear distinction between the enactment of the laws and then the implementation.
Okay.
You know, and that for me, I think when it comes to the enactment of laws, Ghana is best known in that area, even at the international level.
A shining star.
Yes, but when it comes to the implementation of those policies, we lack a lot in terms of providing the logistics to be able to deal with the issue. When it comes to abuse of children in countries, we are among the 20 countries in the world that really abuse children. But then yet, we are the first to ratify the UN Convention on the Right of the Child. And that raises a whole lot of questions. If you've listened to Ofaya, he's trying to deal with the difficulties.
Yeah.
You know, he's trying to deal
And he's doing a great job.
He's doing a very great job, you know. But for me, I think that he's doing on the wrong footing, because the thing that he needs to be able to, even to do that, those are not there. So he's basing his argument on the fact that he has to do his best on the wrong foundation.
Wafaya, listening to him, it looks like you're doing your best, but the things, the critical pillars that should support what you're doing and make sure it translates into an impact in the community, those things are absent. That's why you're getting recurrent diarrheal cases, respiratory cases, which really relates to development, poverty, and other factors.
It's true. From what he's saying and what we are seeing, at times they will bring the child to the hospital, we'll manage the child will become fine. Then we discharge the child, when the child goes home. Within 1 week or less than that, he comes back with the same condition, because he goes back to remain in the same condition that brought about the sickness. Let's say the person goes there, they don't have any potable drinking water there. They drink from dams and then gravel pits. And within the short run, that kind of distance can never be achieved. They can't get any potable water within the short run.
So they'll be back.
They'll go and continue with what they were doing, and they come back again within the shortest possible time.
So you are part of the district health management team?
Yes, sir.
You are?
Yes.
Okay. So how do you juggle trying to bring innovation and qualitative change to literally firefighting in the ward? Because you're doing theater. How do you do that?
The management met and they said actually the ward is too small to be a children's ward. So they plan expanding the ward. And then they also said they have put in their budget to buy more children's cots. But as of now, if they don't expand the ward, they can't bring the course because there won't be a place to put the course.
The conditions, I know you're doing your best.
Yes.
I know now, and I understand that if you leave the children's ward to go to the female or to go to theater or to do any other thing, that ward is crippled. How do you feel about these conditions? You've been there since 98.
Yes.
You went further to say that this is short term, and then you said 5 years. For me, 5 years is not short term.
Yes.
You've been patient, enduring.
The situation there is not easy. It's tiring.
It's tiring.
But, it's tiring. But on humanitarian ground, I have the feeling for helping. Because when I close, because theater is not a place that is always busy. So at times, it's less busy. And when I go home, and then I feel that I'm wasting my time. I'm not doing anything in the house. I go
you
back
are
to
devoted.
the work. Yes.
Committed.
Yes.
And that's what keeps you there.
You know, handling children in Ghana is a bit complex. And I always tell people that until you find yourself before the law, you wouldn't know the implications. Because as a medical officer, he owes children duty to the extent that you owe children standard of care. You know, so if you are not careful in terms of how you even administer your professional work, you think that you are committed and you want to support the community, but when you are before the law, it can also go against you. So there are a whole lot of things that we need to charge the system to provide. Otherwise, we put people at risk.
They say people get the quality of service they ask for, they demand, and you're suggesting this legal approach, right? And that there are legal remedies. I mean, explain to us, I mean, what can you take to court? I get there, there's a queue, or there is no bed. I'm asked to lay my child on the floor. Can I take that to court? What kind of infractions can we reasonably and meaningfully take to court?
Yeah, I think what we can do in this direction is that, one, the law has provided a foundation for the kind of care that children will need when they go to hospital, which of course means that they have to meet a certain standard, you know, of care. If a child of course is entitled to health care, so by virtue of that, you expect certain standards. So if those standards are not there, then you can question the hospital as to why those standards are not there. When it comes to sending issues to court, sometimes you need a fit person to be able to do that on behalf of the child. You know, that is what sometimes makes it very difficult to specifically send certain issues to court in terms of how you want to deal with it, because there are issues where children go to a hospital and as a result of negligence, the child dies. You know, and parents are not ready to pursue the case. You know, as long as they are not ready to pursue the case, it will be very difficult for me to say that I want to pursue the case unless I get that guarantee from them. But when it comes to providing certain standards, you know, this is what we want to go to court on the basis that the law says that the best interest of the child needs to be defined in whatever we do.
Right. Maybe I should put Wafoyao in the dock, right, and ask you, well, if you had a case like this where somebody, despite your hard work and perseverance over the years, somebody says, look, you've not done the best for these children or this community, what would you make of that? What would be your response?
Actually, the person will have a reason for taking me to court. Maybe my child was brought to the ward and he needed this and this, which you people didn't do. The first of all, I have to find out whether that thing is from me or from the facility. Because maybe, for instance, somebody brings a child who is sick, and then maybe I prescribe some medication. And the medication is given, and the person claims, now the child is dead, so it's because of the medication you wrote that killed the child. That one is different. But if the problem is that the child was brought to the ward, and maybe the child needed oxygen to be given, and the child wasn't given oxygen, then the child died, then that one, I don't think I will take it as my responsibility, because when the child comes and needs oxygen in a critical condition, we refer the child, because we don't have an intensive care unit at the hospital.
At that referral level, you don't have that?
Yes, we don't have intensive care unit at the hospital.
But let me ask you this. Do you agree with Bright that generally people, your clients, your patients, do have a right and do have a case in instances where they are shortchanged by the system?
Most of them, they have a case. You will see that my patient needed this and it wasn't done. But because they don't know where to pass, they just tend to forget of it. And Salaga is predominantly a Muslim community. Whatever happens, even if you see somebody use a motor and knock a child or this and the child die, they will say that it's God who has brought it, so let's forget.
The dilemma is whether we should take this advocacy and legal path, or we should just work with the Famanyami. God will provide system or syndrome. Once again, I'll thank Bright for sharing with us interesting legal perspectives and advocacy angles as well. And Wafoyao, we congratulate you for I don't know whether you are using the multi-system, but all the hydra-headed things you do as an octopus, right? We congratulate you. Keep doing it. And for you, our viewers, we say thank you, but we'll follow up again to find out whether some critical changes have started taking place. Once again, my name is Notedwa. Thanks for sticking with us on the Maternal Health Channel.
This girl is anemic and she needs blood quickly. Blood cannot be made. Donate blood to save a life.
We don't expect any woman to go to the hospital to deliver and die.
It makes me feel angry angry because it looks as if we are toying with the lives of women.
Bi eni obanu afọ do ke bile ba hia boda je no ti ona mi se o wo ku be ni o hia fe na mi se se ko bile ba hia fe ngon ma mi fe jo ku to fe e fine no die papa.
Every maternal death tells a story, and these are the stories as policy makers that we are interested in knowing to enable us put in place practical solutions to these avoidable deaths.
Masama mede magana fo no se mesre biala se be fe yefunu a ebia be hwe no ho so ye ama awo na ye kwaye mma no no so watwa osanse ma ye ba atane ma ye hema yetini sa ne ye ho tete.
My name is Dr. Koma S.J. Huapia, the country director for IPAS Ghana. IPAS believes that no woman should die giving birth to another life. Every outcome of pregnancy should see a woman who is alive. Maternal mortality is a rare indicator in public health, and Ghana should strive to reduce the institutional figures of 351 per 100,000 live births. We should help reduce such needless and senseless deaths amongst our women. Keep watching.